Thank you very much for joining us today. I'm looking forward to a great session with Altayeb talking about psoriasis in the second of the London Dermatology Centre masterclasses. So I'm just going to ask Alla to introduce herself, and then I'll load her presentation and she'll take you through it.
Hello everyone, my name is Dr. Alla Altayeb. I'm one of the consultant dermatologists here at the London Dermatology Centre. We'll have a good conversation today about psoriasis.
Okay, thank you very much, Alla. I'm going to load your presentation up now, and we're going to swap places, and Alla will take you on from there. Okay.
Right, so today's topic is going to be psoriasis. We're going to be covering just what psoriasis is, different types of psoriasis, when to refer, treatments for psoriasis, and then some top tips for GPs that's obviously going to help you in the primary care. Right. Okay, so in terms of the epidemiology of psoriasis, we all know psoriasis is a very common condition. In the UK, the prevalence of psoriasis is between 2 to 3%, and worldwide 1 to 3%. Same ratio between men and females. And we know it's a chronic condition. So at the moment, we don't have a full cure for psoriasis, but there's been significant developments in terms of biologics, where we've been getting excellent control of the disease, up to 90 to 100% clearance with the new biologic, which is a really exceptional advancement in psoriasis. So in terms of the etiology, it does have complex etiology in the sense that about over 30% of patients do have a genetic predisposition to psoriasis, which can be switched on and off by external triggers. And I will be talking about the certain triggers. But then when that gene is switched on, it does activate the certain immune pathway causing psoriasis. But it's only in over 30% of patients with psoriasis that they have the gene. And then the rest of it is a complex immune-mediated pathway that causes psoriasis. But it's important to understand there are significant triggers that can make it worse, which can be modifiable, which we will speak about in a second as well. Right, so in terms of the genetic predisposition, we know that certain HLA subtypes make people more likely to get psoriasis. A specific one, HLA-CW6, quite academic, but it just means people who have a genetic predisposition can get psoriasis much earlier. It can also be a bit more severe than the ones without the genetic predisposition. And then with regards to psoriatic arthritis, HLA-27, which we know can contribute to other conditions like inflammatory bowel disease, ankylosing spondylitis, does make people more prone to getting psoriatic arthritis. And this cohort of patients can actually sometimes develop psoriatic arthritis first and then get the skin disease. So it's just one thing to keep in mind as well. And then we spoke about family history. So family history isn't a specific criteria to diagnose psoriasis, but as I said, because 1 in 3 can have family members, so it's particularly helpful with pediatric patients, because psoriasis in a pediatric cohort can look like eczema initially and can be misdiagnosed as discoid eczema. So having a family member with psoriasis just makes you wonder, to keep an open mind that the diagnosis might present itself later as psoriasis. Initially can look like eczema. It's not going to matter much in terms of the treatments, because for pediatrics we're using milder steroids anyway. But if a family member does have psoriasis, just to keep an open mind that this could be psoriasis. And then there are other genetic loci that have been identified. So in terms of the immunological pathway, the fact that we have very good understanding of the immunological pathway means we were able to get all these new biologics, the targeted treatments. So rather than pan-suppressing the immune system for the patient, we know that T helper 1 and T helper 17 pathways are the ones that mediate psoriasis. So having biologics targeted to these pathways means we can suppress this one specific pathway, get good control without causing many other side effects as compared to the traditional immunosuppressive medications. And it's important to also understand the difference between eczema and psoriasis in terms of which pathways are involved. So for example, during pregnancy, T helper 1 pathways are actually suppressed. So actually patients who have psoriasis, while they're pregnant, their psoriasis might be better. Unlike eczema, the T helper 2 pathway, which is what causes eczema, it's unchanged. So patients with eczema can either have the same level of eczema or it can get worse during pregnancy just because of the physical stress of pregnancy itself. But it's just one thing to inform patients, because in the primary sector, I'm guessing you're seeing the patients more frequently, and if they're planning to conceive, it's just something you can speak to them about in terms of planning their treatments while they're pregnant. In terms of the environmental triggers, and these are the modifiable environmental triggers, they can make a massive difference to flare-ups of psoriasis or the severity of psoriasis. So we know that alcohol consumption can make psoriasis worse, specifically binge drinking, because that just causes an inflammatory process and it causes psoriasis to flare up significantly. Obesity, we know that obesity does have a significant impact on psoriasis, and now that with all the weight loss injections, we've actually seen a surge of patient psoriasis getting better just because you're able to lose that weight, similar to other conditions like hidradenitis suppurativa. So we know that obesity does have an impact in terms of making the psoriasis worse. And then obviously stress and anxiety can make psoriasis worse. And then particular drugs can also make psoriasis worse. And the common ones are beta blockers, lithium, antimalarials, NSAIDs, and ACE inhibitors. Now, when it comes to drugs, if there is a suitable alternative, we usually ask the responsible clinician to switch if we're unable to control the psoriasis. However, for patients with a cardiovascular events who've been on beta blockers and they need them because of the cardiovascular event, we usually treat the patient symptomatically, because we know that patients with psoriasis are actually, if anything, at higher risk of getting cardiovascular incidents. So keeping them on medications like beta blockers and ACE inhibitors is actually more important than the flare-up sometimes. So we try and manage around that because of this increased cardiovascular risk for patients with psoriasis. Because psoriasis itself is a pro-inflammatory condition, and these people are much higher risk of getting cardiovascular events. So in terms of the types of psoriasis, I'm sure you've all seen psoriasis. So the most common type of psoriasis is plaque psoriasis, extensive surfaces around the umbilicus, lower back. These are the common sites. And then we also have guttate psoriasis, which is described as raindrop, usually trunk involved, usually younger patients, post-strep infections. Sometimes we actually describe it as a small plaque psoriasis, but it does have a distinct distribution, trunk and raindrops. We'll look at photos in a second. And then we have pustular psoriasis. So pustular psoriasis, we have the generalized, luckily not very common, which does have a different immune pathway as compared to the other types of psoriasis, which I'll speak to you about later on in the presentation, because with regards to the biologics. And then the one that's a bit more common is pustular psoriasis, which is palmoplantar psoriasis, which is palms and soles. And one way to differentiate that between palmoplantar pustulosis and Pomphylix eczema is you would see pustules rather than just vesicles with clear fluid. And with palmar psoriasis, usually the instep is the first bit that's affected. So that's one way of kind of differentiating it from eczema. And again, psoriasis, always well-demarcated plaques, well-demarcated rash. Whereas with eczema, you will never see the edge. It's always a diffuse type of erythema. So that's one way of kind of differentiating between Pomphylix type of eczema versus palmoplantar. And then we obviously have the emergency, which is erythrodermic psoriasis. 90% of the surface area is covered, is red. If patients don't have an underlying diagnosis already of psoriasis, it's important to look at the appendages and the scalp to try and find out clues to what could be the underlying cause of erythroderma, like nail involvement, scalp involvement, family history. All of these things will help. But most of these patients anyway need to be admitted because they need to be closely monitored. And if there is no diagnosis, usually we do a biopsy for to rule out eczema, psoriasis, T-cell lymphoma, other causes of erythroderma. And then we have the tricky type of psoriasis, which is the inverse or flexural psoriasis, which usually affects the underarms, axilla, submammary, groin region. It is not scaly, as in contrary to the normal psoriasis. Usually shiny, erythema. Then again, the way to diagnose it is the well-demarcated nature of it. Look at the appendages if there's any other signs elsewhere. Again, family history. So all of these things will help diagnose rather than just, yes.
Take you back to your
Dermic, yes.
You say it's an emergency.
Yes.
And I'm not talking as a GP.
Yes.
How much of an emergency is it? Do they need to be admitted? Do I get a nurse? So how
So
will I know?
Yes, go ahead.
How will I characterize that? Somebody comes in with very red skin.
Yeah. So if they have redness that covers more than 90% of the body surface area, so regardless of what's causing the erythroderma, they need to be admitted. And the reason for admission is when the skin is that inflamed, they're losing so much water, they're losing heat, they will be hypothermic, they will be dehydrated, there will be an electrolyte imbalance, they might be feverish as well, high because the skin barrier is inflamed, high risk of infection. And obviously you need to make sure to find out what's the underlying cause. If it is a T-cell lymphoma, they need to diagnose. So
be hypothermic rather than hyperthermic.
Hypo, yes.
Okay.
Because they're losing heat.
Well, those are the key issues for me as a GP.
Yes. Rather than hyper. They can be feverish if they have a superimposed bacterial infection, but generally they'll be losing water and heat. They will be shivering in front of you. You will see them. So they need to be closely monitored. They need fluids. They need extensive topical treatment. They need their bloods checked. So all of that.
One of the very tempting things about being a dermatologist is there's only about 3 emergencies.
Yes. Yeah, that's why we chose it. But so it's important to know which ones.
Which ones are
Yeah. So unlikely that if you speak to a medical registrar, unlikely they will reject it because they obviously know these patients are very unstable. They can destabilize even very quickly.
Thank you.
So in terms of the different types we were just discussing, so can you see my mouse? Hopefully you can see my mouse. So this is more the small plaque / gut tape type psoriasis. This is the common plaque-like psoriasis, external surfaces, well-demarcated plaques, similar with the scalp, well-demarcated plaques, usually affecting the hairline. The back of the neck is one of the commonest sites. Ears, the outside of the ears usually affected. And then this is just a typical photo of gut tape psoriasis, younger patients, trunk, post-strep infection is usually what triggers it. This is the.
Just for our online viewers, we are taking questions from the audience as the presentation goes on. And if you don't mind waiting until the end of the presentation, our online audience, you'll be able to ask any questions of Alla right at the end. Thank you.
Okay. So just going back to the inverse or flexural type psoriasis. So what I see biggest mistake is a lot of the time is misdiagnosed as intertrigo. So the most important thing to understand about the difference between this and intertrigo, with inverse psoriasis, well-demarcated plaques, there are no islands outside of the plaque. So usually these scattered islands around the plaque is what would make you think of candidal infection as compared to psoriasis. Plus, again, a good history, nail involvement, scalp involvement, joint involvement, all of that will get you down to narrow what the diagnosis is and the symmetrical nature of it. So if there's good symmetrical distribution, again, that will make you think of inverse type psoriasis rather than candida. But the tricky thing is you can get superimposed candidal infection on top. So for example, this photo of the axilla, you will see some white, creamy discoloration on top and some maceration of the skin. So this is probably someone who has psoriasis with intertrigo on top. And it's important to recognize that because you can use topicals like Trimovate, which contains a steroid, antibiotic, and a nystatin, or Lotriderm, which contains clotrimazole and Betnovate strength steroid, to cover all bases. So you're covering all bases that way. Even if you have diagnostic uncertainty by using something like Trimovate or Lotriderm, you're kind of covering all bases at the same time. Right, so this is the palmoplantar pustular psoriasis. Again, you can see the well-demarcated plaque. You can see the instep is usually the first bit that's affected. So that's the arch of the foot, usually was the first bit that's affected. And then you can see the pustules rather than vesicles. So that's the difference, because we also get this confusion between Pemphigus eczema versus palmoplantar pustulosis. So that's the difference. You will see pustules rather than vesicles, well demarcated rash rather than a diffuse type of rash. And then this is an erythrodermic patient. Usually they're just red. You wouldn't see any scaling. You wouldn't see much of any clues other than they're just red, 90% of the surface area covered. And then it's up to the dermatologist to kind of find out what is the underlying thing that's driving their erythroderma after they get all the needed emergency therapy. Right, so we've done that bit. So in terms of the nail and scalp involvement, so the main thing I think I want to emphasize are patients who have nail and scalp involvement are 3 to 4 times more likely to get psoriatic arthritis. So it's very, very important if you see a patient with really dystrophic nails, a lot of thick scalp, psoriasis, ask about pain, joint pains, swelling, and stiffness, because these are the kind of patients who will get early psoriasis and more likely to get it than others who just have skin involvement without the nails and the scalp involved. And then the commonest sign in terms of nail involvement is pitting. I'm sure you've all seen pitting. You can use some light shine over the nail just to see it. It makes it a bit more obvious. Make sure you check the toes as well, because that gets forgotten most of the time. I've had patients that have had no changes in their hands, but it's all about the toes. So just make sure you look at the toes as well. And the trick is symmetrical changes, not necessarily the same fingers in both hands. Both hands are affected, both feet are affected. So that's, again, just points you towards the diagnosis, especially when things are looking a bit vague. That's just all these things are going to help you to reach or narrow down the diagnosis. So when it comes to nail psoriasis, unfortunately, nothing topically really helps. So you have to aim for systemic treatment, similar to nail fungal infections. Anything topical is not really going to help. You need more of a systemic oral treatment. So as a weighting measure, you can give them hydroxycortide tape, which is the steroid tape, just because of the ACE of its use. Usually they just wrap it around their fingers. They can alternate between that and a strong steroid. The dermavates, they can even do it under occlusion. It will help a little bit, but nothing's going to really help nails other than oral or a systemic treatment. So these are just some of the findings that you would see in a psoriatic patient. Pitting in this photo, subungual hyperkeratosis, onycholysis, separation from the nail bed, and the just general dystrophy of the nails symmetrically, both hands, both feet. So in terms of psoriatic arthritis, I think it's really important to know when to urgently refer to rheumatology and when to just routinely refer. So urgent referral to rheumatology, usually when you have a hot, swollen joint. So a patient with a hot, swollen joint, known psoriasis, or you have any other clues in terms of psoriasis, they need an urgent referral to rheumatology. If they just have chronic pain, morning stiffness, make sure you ask about axial involvement. Those can be referred as routine, but it's the hot, red, swollen joint that is an urgent referral, because that's active inflammation. The joint destruction is literally happening as we speak when you're seeing that patient. So those need an urgent referral. And then we discussed how nail and scalp is usually strongly associated with psoriatic arthritis. So dactylitis, so don't miss that, which is just sausage fingers, hot, swollen joints. One way of just making sure whether the joint is inflamed or not, just get the patient to put their fingers side to side or the hand side to side so you can compare and see whether there's swelling, because sometimes it can be very subtle, but that's one way of finding that out. And then again, look at the feet just to see whether there's any swelling or redness there as well. So in terms of treatment, so it's always in dermatology, everything is always the stepwise approach. We always start with topicals, light therapy, oral treatments, and then biologics if we have biologics for that condition. And we will go through them in detail. So in terms of the phototherapy, I'm sure you're aware there's UVB and UVA. UVB is actually available in the private sector. UVA, which is PUVA, is probably more treatment that you would find in the NHS rather than private sector. So in terms of topicals, so usually our go-to topical treatments is Instellar foam. So the reason we prefer Instellar foam rather than Dovabet, which is usually the classic that most people have been using, is Instellar is a smaller molecule. So actually it goes penetrates, penetration is actually better, and that's why the results are usually better, even though the ingredients are the same, which is a betnovate and a vitamin D analog, but Instellar is better, and actually Instellar we have data that can be used as maintenance twice a week, unlike Dovabet. So that's why we usually prefer Instellar foam. Again, the fact that it's a foam, there's a large surface area involved. Foam is much easier to apply than an ointment. So that's usually our go-to when it comes to topicals. The way we prescribe Instellar, usually for a flare-up, once a day for 4 weeks, alternate days for 4 weeks, and we know that it's safe to be used twice a week as maintenance for patients who have constant flare-ups or psoriasis that are a bit more difficult to manage. In terms of face, this is us talking about trunk and limbs. Instellar can also be used on the scalp. It is a bit more greasy as compared to Beta Cap and Betnovate lotion, but it definitely can be used on the scalp. So a patient can maybe reserve that to the night before they wash their hair because it just penetrates better as compared to the other topicals. And just to emphasize, they can stay on twice a week maintenance. In terms of facial psoriasis, usually, obviously, we go for milder steroids, something like Humavate for the face, hydrocortisone or Humavate, once a day for a week, alternate days for a week. And then in terms of the maintenance for the face, they can be on things like Protopic, which is a non-steroid anti-inflammatory topical. They can use that 2 to 3 times a week as maintenance. It's very safe. It's licensed for kids over 1 year old. So it's very safe as a maintenance after they deal with the initial inflammation with a milder steroid. The problem with Protopic is straight into a very inflamed skin, it can sting. So we usually use milder topical steroids first to get rid of that initial inflammation. And also actually the substance that causes the stinging gets deactivated when it's put in the fridge. So I do tell the patients, put your Protopic in the fridge, it doesn't stink as much. Also, it's going to give them a soothing effect as well. With regards to the scalp, I think a lot of people find scalp psoriasis challenging in terms of the topicals. So usually our go-to is Sebco lotion, which is coconut salicylic acid coal tar. In the box it says soak over 2 to 3 hours, but actually we tell the patient to soak overnight. It can't stain their bed sheets, just wearing like a shower cap or sacrifice one of the bed sheets just because it does stain it, rather than just a couple of hours, because overnight would definitely be much better than just hours. And then with the Capicel shampoo or the prescribed shampoos, people make the mistake of putting it on, rinsing it off quickly. Itself is a treatment. It does contain coal tar, contains salicylic acid. It does need to be in contact with the scalp for at least a few minutes for it to do something. So we tell the patients, put it on your scalp, wash the rest of your body, and then rinse that off, just to give it some time to actually work on the scalp. With regards to steroid preparations, I prefer Betnovate lotion than other Beta Cap, just because the lotion is water-based, less greasy. As I said, Instellar can be used, but it is more greasy. But it's nice just give them the option. If grease is the reason why they're not using it, Betnovate lotion, because it's water-based, it will probably, the compliance will be better with that. And then always find any ointment that the patient is going to use. Then we don't really have a preference in terms of which ointment, as long as it is an ointment, not a cream. Ointments don't contain as many preservatives as compared to ointments. So anything white has more preservatives. Anything clear does not have that many preservatives. So we prefer an ointment, also better in terms of heat loss and skin barrier. So we need an ointment. And then for thick plaques, for example, palms and soles, when they're very thick, do think of diprosalic because it does have a higher concentration of salicylic acid to break down the scale, because the scale needs to be lifted for the steroid to do anything. So think of something that contains a higher concentration of salicylic acid when dealing with thick plaques. So in terms of light therapy, so as I said, UVB is available in the private sector, whereas UVA is only available in the NHS. Usually it's effective for skin type psoriasis. Obviously, it does nothing for the nails. and it's very limited effect on the scalp just because of the hair. So it's usually mostly for the skin psoriasis. It is usually 30 sessions. Patients have to come twice a week for the session, so 15 weeks. And we usually up titrate depending on the patient's skin type and the reaction to the treatment. Maximum is about 5 minutes, initially it's seconds, so it doesn't really take long at all. And then with thick palmoplantar type psoriasis, Puva is actually a better option just because it's a longer wavelength. It gets in deeper to thick plaques, and it does have much better efficacy with regards to thicker palmoplantar psoriasis, sometimes in combination with acitretin, which is one of the systemic treatments that we give for psoriasis. It does actually have better efficacy when combined. Right, so that is topical treatments, and that's light therapy. If these people failed, if they've had a very good optimized topical treatment for up to 3 months and you're really not getting anywhere with it, do have a think, okay, we're reaching a point where we have to refer them to dermatologists, we have to refer them to secondary care, rather than waiting much longer. So we say 8 to 12 weeks of good optimized treatments, take into consideration environmental triggers, alcohol, obesity, drugs, all these things, all the modifiable risks, and they're still struggling, refer to secondary care or dermatology. So in terms of the systemic treatments that we use, so we have 3 options. So we have methotrexate, cyclosporin, and acitretin. We usually prefer methotrexate in terms of its safety profile, and it's not just an immunosuppressive medication, it's actually immunomodulatory, which means it does have an impact in terms of changing how the immune pathways are working. So if patients decide to come off it, their psoriasis and their baseline psoriasis might not be as bad because methotrexate has an immunomodulatory effect as well. So we usually like methotrexate, usually our go-to. The problem with methotrexate, it does take 2 to 3 months to actually work. So there's a delayed onset. And obviously you need to select your patient appropriately. If the patient drinks a lot of alcohol, it might not be safe to give them methotrexate. It's cleared by the liver. So just keep those in mind. And also the monitoring in terms of blood tests. Are they going to comply to having your bloods checked? Cyclosporin has an excellent and rapid effect. Usually it works within days. So we've had patients who have had very bad psoriasis. They have the wedding coming up. They have a graduation coming up. Cyclosporin is the best choice in those kind of cases. The problem with cyclosporin is it cannot be used for over a year. Some places 6 months to a year, just because by default, eventually it can cause renal failure. So we like it as a quick switch off, a quick control, but it's not something we will rely on over a long period of time, especially younger patients who are going to have psoriasis for so many years. It's not really a good option to keep them on it for so many years. And then acitretin. So acitretin does have the benefit of being a non-immunosuppressive. So it does not suppress the immune system. So if you have a patient who's worried about catching infections while on an immunosuppressive tablet, acitretin is a good option. Again, select the patient appropriately, because if there's an issue with alcohol intake, acitretin might not be a good option. Lipids, acitretin might not be a good option. But otherwise, it's an excellent non-immunosuppressive option, particularly for palmoplantar psoriasis. So we know it actually works very well for this subtype of psoriasis. With women, it's contraindicated in women with childbearing age, and the reason it has a very long half-life. The washout period after the drug is 3 years. So we don't prescribe it for women of childbearing age, especially if they're still planning to conceive. If they've completed their family, that can be a conversation to have, but by default, usually we try and use one of the other 2 options. Then comes biologics. So when do patients qualify for biologics? Usually when they fail 2 systemic treatments, or the 2 other options of systemic treatments are contraindicated. So we've mentioned if someone is an alcoholic and you don't think methotrexate or acitretin is going to be an option, or they've had one of them, had a bad reaction, or on it for over 3 months and failed it. So if they failed 2 systemics or they're contraindicated, then they move on to a biologic. And when they are on a systemic, and how we define they failed systemic treatment, is if their PASI score remains over 10 or the DLQI quality of life score remains over 10, then they do qualify for a biologic. In most centers across the NHS, the usual first line is adalimumab, which is an anti-TNF. It has been with us the longest, and because it's been there the longest, we do now have biosimilars. And the benefit of having a biosimilar is much cheaper as compared to a biologic. So a biosimilar, for example, costs $250 a month, compared to a biologic would have cost over 10 grand or 14 grand a year per patient. So massive cut in terms of cost with the new biosimilars. And then after adalimumab, if you are moving to a different biologic, usually the way we think about it is there joint involvement versus there isn't? Is it just skin again versus joint? So if it's just skin, interleukin-23 is usually the choice because they have a better safety profile. However, if they have joint involvement, specifically axial joint involvement, usually interleukin-17 would be the choice. That's usually how we make our decision with biologics, based on joint involvement and just skin involvement. And also you have to think of the comorbidities of the patient. If they are someone with history of severe heart failure, adalimumab might not be a good option. If they are a patient with family history or themselves have inflammatory bowel disease, interleukin-17 is not a good option because it can trigger inflammatory bowel disease. So obviously you have to select your patient appropriately based on skin involvement, joint involvement, and their comorbidities. And that's usually how the selection is done. So I'm not sure if GPs, you do calculate the severity of psoriasis, but if you do calculate it, it's easily done online because there's online calculators where you basically just, the body is divided in two different parts, upper limb, lower limb, trunk, head and neck, and then erythema, thickness, and scaling, and then they get their PASI score. And just if you want to add that into the referral, says one of the things that are available in online. So coming to top tips, so I think that's probably the bit that will help most of you. So Instellar foam, again, I explained why we think it's the topical of choice because of the better absorption. And then we know that we have safety data in terms of maintenance twice a week. So don't forget that, definitely can be used twice a week. For flare-ups, they can always go back to once daily, 4 weeks, alternate days, 4 weeks, and then twice weekly is maintenance. For the scalp, Sepco, rather than just hours, soak overnight. Betnovate lotion, if they want something less greasy. Capacel shampoo, again, leave on the scalp for a few minutes. And then we discussed flexural psoriasis, how we can get superimposed infections. So think about the topicals that contain antibiotic and an antifungal as a good option for good control. And then, as I said, always aim for an ointment rather than a cream. And again, people complain it's greasy, it's sticky, we don't like to use it, it doesn't, especially if their job involves speaking to people. One way to deal with that is applying it on wet skin, because it's like Vaseline consistency. Oil and water don't mix, so if the skin is wet, they're using less of it, it slides easier and becomes less sticky. So there's just one way of doing it. So what's the role for you guys in the primary sector? So it's really important to recognize that psoriasis is a pro-inflammatory condition. These patients are higher risk of cardiovascular events, non-alcoholic fatty liver disease, and depression. So it's really important to keep that in mind when you're seeing your patients. Some studies suggest doing an annual cardiovascular risk, but I think it's not really practical to do that. If you have a patient with a lot of other risk factors, maybe aim to do it annually, especially if they have psoriasis, and have a lower threshold, because most of the cardiovascular calculators that you have to calculate the risk doesn't take psoriasis into account. So if it is just on the upper end and not really abnormal, the fact that they have psoriasis means they're actually more likely to get that cardiovascular event. So we need to keep an eye on all the modifiable risk factors, blood pressure, lipids, weight, smoking, alcohol, all of that needs to be taken in mind. So NICE does suggest doing it for psoriasis patients every 5 years. But if the patient is of high risk, then an annual checkup and a risk assessment is probably prudent. And then even mild psoriasis, it's not about the severity. Even if they have mild psoriasis, they're still at higher risk of cardiovascular events. And then obviously we discussed about managing the triggers, weights, alcohol, smoking. Look at their drugs. If they come to you suddenly with a flare-up of psoriasis, just try to investigate what happened, what changed. Is it a new drug that causes psoriasis to get worse? Is it a recent infection? COVID, there was a recent surge of COVID, and COVID did cause significant flare-ups of psoriasis. But always ask for streptococcal infections. Those things are very common to cause flare-ups of psoriasis. And then we discussed the importance of asking about joint involvement, specifically for patients with nail and scalp psoriasis. And we've asked, you have to ask about morning stiffness, swollen joints, pain, and look for hot swollen joint, urgent referral to rheumatology. Okay, and then we said when to refer. So as I said, good, optimized topical treatment, 8 to 12 weeks. They're not getting anywhere with that. Think of phototherapy, think of systemic treatments. Patients with nail psoriasis, they will need a systemic treatment. Nothing topically is really going to work. And then they can also be, if they do have an area of high impact, so if they just have genital severe psoriasis, not anywhere else, they still do qualify for secondary care referral because it's a high impact site. And they are changing the guidelines to be able to get these patients on a systemic and a biologic much quicker if they have a high impact site. And then emerging therapies. So for pustular psoriasis, there are new biologics coming up, interleukin 36. So that's good news for patients with generalized pustular psoriasis. Luckily, it's not very common. JAK inhibitors are not approved for psoriasis, just skin psoriasis. It is approved for psoriatic arthritis. And if a patient is on a biologic and planning to get pregnant, we know that citralizumab, which is a type of anti-TNF biologic, is safe during pregnancy because it does not cross the placenta as compared to the other anti-TNFs. But women who stay on it until the third trimester, we just, as a GP, you might just need to let them know they need to delay their vaccinations, their baby's vaccinations, to 6 months after delivery. But those are just extra pieces of information. So, so we've just covered psoriasis. We emphasize the importance of understanding the risk, cardiovascular risk in these patients. We discussed topical management. Nail and joint usually require systemic treatment. And just think of the stepwise treatment: topicals, light treatment, systemics, and biologics. And those are my references.
Okay, thank you very much. We swap places, and then I will see if there's any questions from our online audience. Okay, thank you. Do you have any questions? Any of you? Please speak up.
So I was going to ask about shampoos.
Yes.
So it's all well good talking to patients about Capsule and Altar,
Yes.
but honestly, it appears to smell like mothballs all day.
It is.
So it used to be Alpha-Sil 2-in-1, but
Yes.
it just seems to have gone out of widely used.
So the trick is they don't need to use it all the time. So if they're having a flare-up, so initially they can use it twice a week for a month, and that can be used twice a month as maintenance. So it's just about getting on top of the initial flare-up or the thick scales. Once that's controlled, 2 or 3 times a month is enough as maintenance.
It's very smelly.
Yeah, did my face smell that?
So we've had a question in the chat, or a request for a copy of the slides. Would that be okay to supply a copy of the slides?
We talked about ciprofloxacin. I mean, just in the afternoon, we actually have got formulated dermabate plus 5% liquid tar, which is quite rare, but that's really good for thick plaque psoriasis.
Yeah.
And obviously, you don't want to be smelling them like mothballs, so we reserve that for night time. So you can wash it off. So only your partner gets annoyed, not everyone else, which is okay, really.
Which is a good combination.
And the other thing is, 50% of psoriasis patients, especially if they're associated with obesity, we can actually do what's called the insulin resistance test. And we're finding, and I think stats show that 50% of patients will have raised insulin, in which case metformin is a really good option help them lose weight, to prevent future diabetes, and so
That
forth.
controls their cardiovascular risks.
Exactly,
Yeah.
exactly.
So that's definitely something to think about. But I think the Diprosal, the fact that it's dermovate rather than betivate, because the usual preparations are betivate and
Yes.
salicylic, whereas dermovate, the one we make here, is dermovate and salicylic acid, so it's a bit stronger.
Yes.
It's a really thick resistance plaque psoriasis.
Yeah, and any questions from our guests?
So I was going to ask about another variant of psoriasis that you hadn't mentioned was hyperkeratotic psoriasis.
Yeah.
So I've seen patients where they just present with what looks like very hard skin on the heels.
Yeah.
Coming in often complaining of sort of fissuring and splits,
Yes.
really difficult to get on top of. And you think, actually, this is just needs a pedicure.
Yeah.
But actually, it isn't just that because they keep coming back again and
Yeah.
again.
But you can't take it to because it's curving or rising and get
but
worse.
you have to keep in mind, is it hyperkeratotic psoriasis or is it hyperkeratotic eczema?
Yeah.
So usually the history of atopy, they're like asthma, hay fever, family history of atopy will make you think is it hyperkeratotic eczema versus hyperkeratotic psoriasis. But actually for these patients, things like Flexitol, which is urea cream, has high concentration urea. You can even get 40% online.
Stings a lot.
Can do, yeah, but if it's really thick hyperkeratotic scale, it's not going to penetrate enough to cause stinging. It's actually going to help. So it's one thing to keep in mind. But it's about, yeah, think of the emollient containing urea, if that's the case.
Or dermovate plus 5% salicylic acid. That's really useful.
Dermatologist is getting them dermovate under occlusion for about a week, 2 weeks.
Problem is when you stop the dermovate, it can rebound. So it's good to have the salicylic or the liquid tar.
Yeah, we have a question from Lata Mutwani. How extensive psoriasis can be treated safely in PR? I'm not quite sure. Oh, how extensive psoriasis, body surface area, can be treated in primary care?
So I think even if it's widespread psoriasis can be treated in the primary care, the trick is it responding to topical treatment or not? So if you've tried the Instellar foam for 8 to 12 weeks, has it helped or not? But obviously, if it's erythroderma, where the person is covered and red head to toe, then definitely not in the primary care. But even if they have extensive plaque psoriasis, you do have to try topical treatments first. If at 8 weeks you're not managing, then definitely refer.
Thank you for your question, Lata. Are you happy with that? Another question here from Bharat Sangtani. Which emollient is best tolerated? Just hold on a second. I need to show that. Oh, it's which emollient is best tolerated, preferred by patients in your experience?
So I do like Citron ointment and hydromol ointment, and because I tell them to put it on wet and damp skin, they're not complaining of the stickiness of it because they're using less of it. It slides better. They can also reserve it to a night treatment if they're finding the ointment during the daytime is very sticky. As long as they use it once a day at night. During the day, they can use cream. That's absolutely fine. But Citron ointment is a good option. Hydromol ointment is a good option. For more inflamed 50-50, is a good option.
Okay, thank you. Next question. Do you suggest a time period, a washout period, when on methotrexate in excuse my pronunciation? Yeah, at the bottom. Yeah. Do you suggest?
You suggest time period with washout period? No, so methotrexate, so it's once weekly. So the reason is it's dosed once weekly, so the half-life is less than a week. So not necessarily a washout period. So it can be switched immediately to another drug.
Okay, thank you for your question. Sam is next one. Methotrexate, I meant to write. So that was just a clarification about the previous question. Okay, thank you.
We don't really have washout periods. It's usually with biologics that we have washout periods.
Right.
These biologics are 4 weekly or 8 weekly, whereas tablets for cyclosporin, which is twice a day, means a very short half-life, methotrexate once a week. But doesn't have much of a long half-life.
Okay. Don't have any more questions at the moment, but I'll just give you a minute if you would like to ask any more questions from our online audience. Anybody here in the clinic wants to ask a question?
Yes, but actually, if patients have got, say, rashes on their back or short mobility problems,
Yes.
the commonest reason for patients not using emollients really is one, they don't like the emollient
Yeah.
stickiness. Two,
Yeah.
they just get fed up
Yes.
applying them all over and then trying to get access to the back sometimes.
So you have emollient spray.
That's what I was going to say.
Yeah, so the emollient spray, which is a spray, it's patients who can't have mobility issues. I've had patients with ankylosing spondylitis, they can't bend. So things like emollient spray is so good. It's still an ointment, but it's easy to spray.
It's like an oil.
I love it. If you're hairy, doesn't matter.
Yeah, emollient spray is a good option.
And I was going to say the third reason for patients not using up at the moment is doctors don't prescribe them enough.
Yes.
Yeah, give them big tubs as well.
Yeah.
Yeah, give them big tubs, 500 grams at least.
There's just some anecdotal evidence about your heel. Patients with keratodermal thing, something to try, and it's anecdotal only, I don't see any evidence anywhere, is dilute urine, your own urine, you soak your feet in it twice a day.
Urea.
Then you try.
Urea.
It's got urea.
Depends how much you smell your own.
Yeah, but you don't have to walk around with this one. If you do that, wash them afterwards. But it's easier, it can be done. You pee on your feet when you're in the shower.
It sounds like one of those things you say, do not try this at home. Well put. This is true. Yes.
But it does work.
Yeah. We don't seem,
All the smells.
we haven't got any more questions online, so anybody else wants to ask a question?
Psoriatic nail disease. So we often, certainly in NHS practice, you come across elderly people who've got really quite looking, fluffy toenails. And how do you easily differentiate? I suspect the answer is going to be you go between sort of extensive nail dystrophy from psoriasis or extensive onychomycosis, because the fungal cultures just, you have to do like 4 or 5 before they ever come useful.
So nail, we would still suggest a nail clipping. So do definitely send the nail clipping, because sometimes you can get both things, not necessarily one thing. So because of the onycholysis, because the nail has been lifted, you can easily get pseudomonas infection, you can easily get fungal infection. So not necessarily it's one or the other. And it's the other history. Is there any other rash anywhere else that's going to point you towards the psoriasis? Or is there any pitting or scalp involvement? Family history, because over 30% of patients with a family history of psoriasis have family history of psoriasis. So other things might point towards it, but there will be some patients where you can't really differentiate and you kind of have to cover both bases. But in an elderly patient, is it more the cosmetic appearance? Are they really, what are you treating?
Choice of footwear and something.
Yeah, So yeah, we still can refer them sometimes to podiatry for good nail care, but past that, sometimes we do nothing.
See, luckily we have access to PCR for our mycology, so we get the result within 3 days.
Yeah.
And we know PCR is very accurate. So from our point of view, if we get a negative mycology PCR, we know it's negative.
That's really useful.
Yeah.
Because unfortunately the NHS was still restricted to scrapings, microscopy, and then that's about it.
So you send them all to us.
Yeah.
Well, we have a comment from Bharat Santani. Thank you for excellent, concise talk on psoriasis. Very useful, thanks. Thank you, Alla. Any other questions?
Yes, I was going to say psoriasis. So often presenting post-streptococcal infection nowadays, none of us is for treating with antibiotics. So private patient, we can get it. But if the patient hasn't been treated and they suddenly sort of come back a couple of weeks later, is it actually still worth giving them a course of ND or not?
No.
So really, once the opportunity's gone, or actually, does it even matter whether the opportunity's gone?
It wouldn't change because most of these patients will have some sort of genetic predisposition.
Sure.
And it's just the strep that just switches that on. And then they will continue to have psoriasis. So it doesn't really matter whether you treated the strep. It wouldn't make much of a difference to the psoriasis. That you will just have to treat topically.
I mean, with gutted psoriasis, generally, it's quite dissatisfactory. I think just trying to treat it topically.
UV.
Yeah, that's it.
Narrowband UV.
Yeah, I mean, no use now. Access to it.
Another comment from Mita Roy. Very helpful presentation. Good, thank you.
And certificates.
Oh yes, those of you who registered for today, you will be able to apply for certificates. The best thing to do is to drop me an email, david@davidwortley.com, or contact the London Dermatology Centre using their website, and we'll get a certificate sent out to you. Really, thank you very much for joining us. We've had quite a reasonable number, I think, online watching us, and a very select audience, of course, here in the London Dermatology Centre. And our future events will be streamed online, but we do encourage you to actually visit the London Dermatology Centre, particularly for the networking opportunities. And we already have some good hospitality and some food. We don't like that to go to waste. So thank you very much for joining us today. I'm now going to end the live stream with a short little video clip.